Hello, my name is Becky Dame, and I will be your moderator for this workshop. We'd like to welcome you to the workshop, Graft-versus-host-disease of the eyes. Before we begin, I'd like to thank Sanofi, who supported help with making this workshop possible. It is now my pleasure to introduce our speaker, Dr. Jessica Ciralsky. Dr. Ciralsky is an associate professor of clinical ophthalmology at Weill Cornell Medical College and a cornea specialist with the special interest in severe ocular surface disease. She works closely with transplant teams both at Weill Cornell Medical Center as well as the Memorial Sloan Kettering Cancer Center to provide comprehensive care for patients. Her practice focuses on early diagnosis of ocular GVHD and both traditional and novel treatments. Please join me in welcoming Dr. Ciralsky.
Thank you so much. What a pleasure to be here and to speak with all of you. I am going to be talking about ocular graft-versus-host and how it affects the eyes. I have no relevant disclosures for this talk. I'd like to start by thinking about how common this is. This is a little bit of a difficult question to answer because the studies are so widely variable. Some studies show it's in 10% of patients and others show it's up to 90%. There was a more recent study that showed 40 to 60% get ocular graft-versus-host. But if you have graft-versus-host anywhere else in the body, and that's chronic graft-versus-host, the amount of graft-versus-host in the eyes jumps to a 60 to 90% chance. So essentially what I tell my patients is about half of all comers are going to get ocular graft-versus-host. But if you have chronic graft-versus-host elsewhere in the body, that number is going to jump to 60 to 90%. Mainly when we're quoting these numbers, we're talking about chronic graft-versus-host, not acute. Acute is a much smaller subset, less than 10%. And interestingly, ocular graft-versus-host disease might be the first affected organ. So you might not have graft-versus-host elsewhere in the body, and it might just come out in the eyes. There was one study that showed 22% of new dry eye patients after a bone marrow transplant presented with dry eyes and inflammation of the conjunctiva, the white part of the eye, without any other graft-versus-host. So it's possible that that could be your first presenting symptom. How does it affect the eyes? Well, essentially, it's an ocular surface problem. And when you think about what the ocular surface is, it's the surface of the eye, the parts that you can touch. In the picture, you can see the eyelids, you can see the white part of the eye, we call that the conjunctiva, and you can see there's sort of this clear dome that goes over the colored part of the eye. We call that the cornea. That's the surface of the eye, the parts that you can touch. There are also parts, if you see in the left picture, that can affect how this ocular surface is affected. The lacrimal gland, which lives in the upper outer part of the eye, is the tear-producing gland. And then towards the nose, we have the tear ducts, nasolacrimal ducts. These are where your tears drain to go down your nose. An ocular graft-versus-host can do a lot of things to the eye, but essentially it's mainly affecting those surface parts of the eye. So on the eyelids, you can get what's called meibomian gland dysfunction, which is where the oil glands are clogged, and we'll see a picture of this in the next coming slides. Sometimes the eyelids can turn in or out. The conjunctiva, which is the white part of the eye, can have redness, what we call conjunctiva, and sometimes even membranes on it. The cornea, which is that clear dome at the front of the eye, can have dry spots. And if you see in that top picture, those are called filaments. They're almost like stuck-on dry spots. They can be really you can have a lot of discomfort with those. You can even have a scratch on the eye, which you see in the bottom picture. And in the most severe cases, it can go on to even create more severe thinning and openings of the eye. Lacrimal gland dysfunction means that gland that lives on the upper outer part of the eye is not producing tears correctly. And then there is a much lower percent possibility of it affecting things deeper in the eye. Inflammation in the eye is what we call uveitis. The burden of disease can be really severe. So essentially, when you have ocular graft versus host, it's like having dry eye, and many times severe or very severe dry eyes. And they've done lots of studies to compare the impact of severe dry eye on a patient's life and have compared it to moderate to severe chest pain. For the most severe cases, it's thought to be worse than a disabling hip fracture. So this can be really burdensome for a patient and really affect their everyday life. So when you come to the eye doctor, what are they going to do? When I have a patient for the first time, I like to do a full exam. So you'll get vision and we'll check for things like prescriptions and glasses, and we'll dilate you and look for all other problems. But the big thing I'm looking for are problems with that ocular surface. And so the most common thing we do is put a little dye in the eyes. Sometimes it's what's called fluorescein dye, which is more of a yellow drop that you may see. Sometimes something called lissamine green, which is green. These are vegetable dyes. They're non-toxic. They go on the eye, and what they do, if you see in the bottom two pictures, are stain parts of the eye so we can see what's going on. The bottom right picture is staining the cornea so we can see dry spots. The bottom left picture is staining of the conjunctiva so we can see dry spots on the white part of the eye, the conjunctiva. The upper right picture are the oil glands that I was referring to, what we call meibomian gland dysfunction or blepharitis. These oil glands almost have like a little white head or a cap on them, and those are abnormal oil glands. The upper left picture is something we look at for evaporation, and evaporation of the eye can be important because if you put tears on the eye or your eye has tears and they evaporate too quickly, you can get dry eye. So two ways to get dry eye: you can not have enough tears and so low production, or you can have tears but they're unhealthy and so they evaporate too quickly. So many of the tests we do are with simple testing modalities like these dyes that we put in the eye. They're not painful, and it just gives us a lot of information to examine the eyes. Not all doctors that you go to may have all of these testing modalities, but there are other ways to look for dry eye and ocular graft versus host. The upper left picture is something we call tear osmolarity, and it checks how salty the tears are, right? If they're really salty, the eye is going to be very dry. If they're not so salty, there's enough tears, and so the eye won't be so dry. It's a nice way of telling us how dry an eye is. There's something on the upper right called topography that gives us a sense of how dry the eye is. You get these sort of blank spots on the eye when the eye is very dry. Moving down to the bottom left, there's a test. It almost looks like a little pregnancy test with the two little lines. It tells you how inflamed the eyes are. Dry eye is an inflammatory disorder. There's a test called Schirmer's where they put this little strip in the eye and they measure how many tears you make in 5 minutes. And that tells us about what's called your basal tear secretion. How many tears do you make in general? And then there are tests that can look at the oil glands. We talked a lot about the oil glands, and we can actually image them to see if they're complete, if they're atrophied, which means sort of dying or not there anymore, or even foreshortened, where they need to be opened up more. So once we have all of this data, or we're looking at a patient, how do we grade this or stage it? Well, it's different for acute and for chronic. Acute, like I was saying before, is very uncommon, but when you get it, it can be severe. Many of the treatments that we will talk about later on apply to both, but when we do acute treatments, they're going to be for shorter periods of time, whereas chronic is probably going to be a chronic treatment. So the 4 stages of acute GVHD staging are: the first one is what we call conjunctival hyperemia, which just means redness. Second one is that redness with some swelling. We call that chemosis. The third one is redness with membranes, and you can almost see that little scarring in that inner membrane. And then the fourth one are scratches on the eye as well, and you can see that staining with that yellow dye. When we get to chronic, there are a lot of data and different staging groups that have worked on how to think about chronic staging. The first one that I want to mention is from the NIH, and this was from 2014. And the way that they think about staging is first, the dry eye has to be confirmed by the ophthalmologist, and then they want to think about symptoms. Does the patient have no symptoms? Then they're probably a score of 0. If it's mild, moderate, or severe, the scores go up. They also think about how many times a patient has to use a lubricant eye drop, like an artificial tear, and if it's impairing their vision. There is another grading scale that I often use more commonly, and this was done by a bunch of experts in ocular graft-versus-host. They met a bunch of times and decided to come up with different variables so that they could give patients different diagnostic categories. So they could tell them, no, this isn't graft-versus-host, or it's probable, or it's definite graft-versus-host. And what they do in this slide is they look at corneal staining, and the corneal staining is going to look at how that yellow dye, what we call fluorescein dye, stains the cornea. So in grade 0, there's no staining. Grade 1 a little bit, grade 2 a little more, and grade 3 even more. I apologize, but it doesn't look like that next picture is coming up. Let me just advance and see. No. But essentially what that injection score is showing is how red the eye is. Score 0 is no redness. Score 1 looks a little bit pink, and score 2 looks pretty red. The next one looks at a questionnaire. And so this questionnaire is going to ask a bunch of questions to the patient like, are you sensitive to light? And if you are, can you grade that all the time, most of the time, half of the time, some of the time, or none of the time? And then what this grading scale does is bring all of this together so that you have the different components. They're also adding in the Schirmer's test, which is that strip of paper that tells you how many tears you make. And then they give you a grading scale to tell you if you have graft-versus-host or not. But importantly, what we need to think about is what do we do with patients once we think they have it, or even are borderline, probable or definitive graft-versus-host. How do we treat it? Well, in order to explain this best, I want to take a step back and think about the tear film, because what we're modulating or changing when we do treatment is this tear film. And this tear film has 3 major layers. The inner layer is called mucin, and this is like mucus of the eye. The middle layer, which is the bulk component of it, is the water layer, and the outer layer is called the lipid layer. So when we think about this, the inner layer comes from little cells on the white part of the eye we call goblet cells. This is not affected that much in graft-versus-host unless you get more severe, or to the end stage most severe, which is very, very rare. So the main things that we're dealing with when we deal with treatment are affecting the water layer and the lipid layer. That water layer is coming from that lacrimal gland, that gland in the upper outer part of the eye that produces tears. And the lipid layer is coming from those oil glands that line the lid. And we showed that in an earlier picture. If you look upper right, those oil glands are producing oil. And when the oil is unhealthy, that tear is going to evaporate too quickly because the oil is not keeping it on. So you do want to get your oil healthy so that your tears last on your eyes longer. So when we think about treatment, our 3 goals are to lubricate the surface, bring back the water, control evaporation by affecting the lipid layer, the oil layer, and then all dry eye is inflammatory, so we do want to decrease any inflammation. What I like to emphasize with my patients, and we talk about this with the other doctors as well, is that most ocular management can be treated in what we call organ-specific treatments, meaning I can give eye drops or treatments that are just for the eye. I don't have to reach to increase your systemic immunosuppression or put you on oral steroids. I can typically control it locally with eye treatments, which is important. So as I think about treatments, I put them into those 3 buckets again: lubrication, how do I get more tears to the surface, control evaporation? How do I help with the oil to be more healthy so that tears don't evaporate too quickly? And how do I treat inflammation? For most patients, I will tell you that we're doing a combination of all three because most patients have multiple things wrong with the tear film. So let's start with lubrication. I'm sure all of you are familiar with artificial tears. This was a picture I took when I walked into a drugstore just to look at the crazy amount of possibilities you have when you have to decide on a tear. It can be overwhelming to look at the tear aisle and try to figure out which artificial tears I can get. And furthermore, there's been recalls recently which have made this an even more complicated story. So what I tell my patients is I break this down into two different ways of thinking about it. Number one is, are they preserved or non-preserved? Preserved tears typically come in a bottle, and non-preserved tears typically come in the individual vials like you see over on the right part of the screen. I prefer preservative-free tears in my graft-versus-host patients because the preservatives can be irritating and a little toxic, especially if you use them often throughout the day. 4 times a day is a pretty common amount of time to use or less, and for those patients you may be able to get away with something preserved, but for anything more than that, I recommend preservative-free, and I like to recommend preservative-free for almost all of my patients. The other bucket that I separate the tears into is what's called the viscosity or the thickness of the tears. I like to think about tears in 3 viscosities. There's tears, there's gels, and there's ointments. Tears are what you probably think of as traditional tears, water drops. Gels have a little more thickness to them. What's nice about that is it lasts a little longer on the surface, but it may blur your vision temporarily. And then ointment is really viscous, almost like a cream that you're putting in the eye. And that can absolutely blur your vision, which is why we recommend it at night and not during the day. But it does last a lot longer. So bringing us to our next slide, a lot of patients come to me and tell me about morning dryness or middle of the night dryness. And they put in tears before they go to bed. Well, often that's not enough. Just to put tears in. Tears are only going to last maybe 15 or 20 minutes. So you have to think about how to conserve that water in the eye and keep the eye lubricated all night long. And ointment will do that for you. So there's many different nighttime ointments on the market, over the counter. You put just a tiny bit, a 1/4 inch, I tell patients, which is the size of a piece of rice. You put it in and close your eyes. You don't want to put it in and go read because you're not going to be able to read and it's going to be evaporating off your eye if your eye is open, so you want to put it in and go to bed. But I will tell you that a lot of my patients hate ointments, and that's common. There are other options for nighttime lubrication. One of them is called moisture goggles, and this is just an example of one of the moisture goggles on the upper right picture. These goggles form almost a seal on your eyes, and that keeps the tears in longer. So you may add a regular tear in before you put the goggles in before bed. What's nice about these is they don't blur your vision. When you need to get up to go to the bathroom or get up to do something, you just take them off, you can see, and then put them back on to go back to bed. What about punctal plugs? Well, I will tell you these aren't my first choice of treatment for patients, meaning it's when I first see a patient, I don't put them in as a first step. I use a lot of them, but I use them after I've controlled the inflammation because what they're doing is blocking any outflow from the eyes. So what I do is I treat the inflammation and then I add the punctal plugs. And so if you think about the anatomy and you see in that right picture, your eyes make tears and then they go through this tear drainage system that goes through the eyelid and then will drain back through the nose. There's a bottom and a top. Usually we plug the bottom one first because if you think about it with gravity, 80% of water is going to go through the bottom. Only 20% is going to go through the top. I find that with a lot of graft-versus-host patients, these plugs love to fall out. So usually we put in the silicone plugs because these stay well in most patients. But in graft-versus-host, sometimes I have to turn to what are called collagen plugs, which go internally because they don't fall out. They do dissolve, so they have to be replaced, but they don't fall out. We also use a lot of medications to help with dry eye. So dry eye is inflammatory, and you want to use anti-inflammatories. So there's different formulations of cyclosporin and lifitegrast. I don't have a favorite of this group, but often we can do a little bit of trial and error and trial different ones. What they do is help produce more tears and decrease inflammation. But it does take a little bit of patience. These medicines take time to reach peak efficacy. Some of them take 3 months to really work well. Some of them work a little faster. But all of them have a little bit of a build to them. So you're not going to feel instant relief. It's going to be over time. And most of them can be associated with some irritation or burning upon installation. So when you put that drop in, it can burn. If it burns, there are a lot of different things you can do to help with that. Sometimes I tell patients put it in the fridge. Cooling it off can help a lot. You can also put some tears in, maybe 5 minutes before or 5 minutes after, to help with the sting. But for some patients, all of the things we've talked about thus far are not enough. And so there are drops that can be made called serum tears. And these are drops made from your own blood. They take your blood, they draw off the clear part of the blood called the serum. They sort of spin it down, add it to some artificial tears, saline, and they make it into a little dropper. You keep it in the freezer until you're going to use it, then you keep one bottle in the fridge and use it until it's gone, and then take another one from the freezer. So you're not drawing your blood every week. You get about a 3-month supply at a time. What's great about serum tears in very dry eye patients is that they're going to simulate or act like your natural tears a lot more than the ones that you buy over the counter. They have growth factors and nerve factors and a lot of healing factors that you're not getting with the over-the-counter drops. For many of the severe dry eye patients as well, we can go into what's called scleral lenses. Many patients come to me and we start talking about contact lenses, and they say, I've worn contact lenses before, but I'm too dry for contact lenses. And that's probably true for traditional lenses. But these are not traditional lenses. These are lenses made for dry eye patients. They are hard lenses, and they're scleral, which means they sit on the white part of the eye, not on the cornea like traditional lenses. What's cool about them that you can see in the upper picture is they're filled with artificial tears. So you put water in them, and then when you put that on the eye, it suctions on the eye. So in essence, your eye is being bathed in a liquid bandage all day long. So it's as if you're putting tears on your eye 24 hours a day. These are not something you can sleep in, so you put them in the morning and you take them out at night, but they are something that you can put on the eye to help throughout the day, helps with pain, helps with light sensitivity, and helps with vision. So it can help all of those things. So the one thing I want to just pause here and talk about are symptoms of graft-versus-host in the eye, or symptoms of dry eye in general. So things that we think of for symptoms are pain. Sometimes people describe it as an irritation, a sticking sensation, like a little pinprick. Some people tell me foreign body sensation. They feel like something's in the eye, grittiness, burning. The eye can look red, but it doesn't have to. Fluctuating vision is another one, where you feel like every time you blink, the vision changes. And some people describe it as tired eyes. So I want to move on to the second bucket, which is to control evaporation. If you remember, we're thinking about those oil glands and how to get healthier oil out of them. So traditional first-line treatments that we think about are sort of warm compresses or heat masks. Sometimes as I explain this to patients, it can sound a little hokey, but the idea is you want to get the oil that is hardened and has become abnormal melted and expressing better. So sometimes when we're pushing on your oil glands, we're grating it. Does it look like olive oil? That's actually a good thing. We want it to look like olive oil. Oil is good for the eyes. But if it looks like toothpaste and it's really hardened, that's abnormal. So where the heat, the warm compresses, or the over-the-counter heat mask that you can put in the microwave work is to melt some of that oil. Lid hygiene is washing the eyes with something. Some people have done the traditional baby shampoo scrubs where you make your own little scrub. You can also buy these as pre-made scrubs. They almost look like little makeup remover pads, and there's many different brands on the market, but essentially they clean off any of the excess oil and clean the eyelids to help express the better oil. We sometimes use topical antibiotics for this. There's one with azithromycin, there's one with tobramycin, and even oral antibiotics like doxycycline can be used to help improve the oil glands. There are also procedures. So when the things that I was talking about on the previous slide aren't working, there are procedures that can help with the lid hygiene. So there's something called BlephX, which you see in that left picture. It's almost like a deep clean for the eyes. There's a rotating brush with shampoo that can sort of really deep clean those oil glands. Or the picture on the right is called LipiFlow, where it has a heat mechanism that heats up the oil glands so that it can melt the oil. And then it has a mechanism that pushes on the eyelids so you can express all of that oil. There are many other eyelid procedures on the market, and these are just some examples of what's out there. You also want to work to decrease inflammation. So I'm sure a lot of you are familiar with steroids because you may need to use these systemically or by mouth for other reasons. In the eyes, they are a wonderful treatment, but they are a double-edged sword. They work really well for dry eyes, but we don't like them as a long-term option because they can lead to an increased risk of cataract and glaucoma. Cataract is more of a cumulative thing. The more you use the steroids, the higher your risk is. You can actually get cataracts from other forms of steroids, so it's not only topical steroids, but cataracts can be treated. So we do think about this and monitor for it. Glaucoma is something we have to monitor for even more closely. It's not common to get glaucoma with steroids, but it is possible, so we watch patients. But I like to use this as a pulsed therapy, which means if you get a flare-up over the year, we need to use 10 days of steroids. That's fine. Or maybe if we're starting a medicine like the Restasis or Cequa, we need to use a little steroid to get your eyes quiet to get you there. That's good for me. So pulsed therapy is common. I don't like it as a long-term option. Surgical options are possible when all else fails. So when conventional medical therapy fails, there are other things we can do. And the goals of surgery are often to help bring more lubrication to the eye. Maybe you have a scratch on the eye that won't heal, and this will help with that. Or maybe you had a scratch or an infection and it led to scarring, and we have to clear that view and restore vision. One simple thing we often do is a tarsorrhaphy. A tarsorrhaphy means we close the eyelid. We can do that with tape, as you see in the right picture, and this is usually when it's temporary, or we can do it with a stitch, and you can even do it with something longer than this kind of stitch that I'm showing, where it becomes more of a permanent fix. But often we do it just as a temporary treatment to help with a scratch on the eye. There's also something called amniotic membrane. Amniotic membrane comes from the inner layer of the placenta. This is a wonderful material that has a lot of biologic properties to help heal different parts of the eye. So it promotes re-epithelialization, which means it helps scratches heal. It helps decrease inflammation and scarring, and can serve as a biologic bandage. So when we put it on the eye, it brings all of these good properties that your natural tears and natural surface should bring to the eye. It can be sewn on, as shown in this picture, where you have to go to the operating room, or it can be done as a standalone. It's almost like a contact lens that has the membrane draped over it. We call it a symblepharon ring. It's a little ring with this draped over amniotic membrane. That can be done in the office. It gets put in like a contact lens and then gets removed. When it's really severe, sometimes we have to go as far as corneal transplantation. This is rare, but we sometimes need to do it when we have to give a patient better vision for a multitude of reasons. Maybe they have scarring, maybe they have haziness on the cornea. And many times it has to be combined with other treatments so that you get a good result. So the timing of treatment, this is also a little bit unclear. There's been a couple of studies to look at should we be pre-treating patients, meaning starting treatment before you have the bone marrow transplant. There's been one big study, but it was retrospective, meaning they looked at patients after the fact and showed that patients that got something like restasis before the bone marrow transplant versus patients that didn't get it till at least 6 months after the transplant, that the patients did better when they got it beforehand. What's hard about this is we probably need some bigger studies to try to figure this out. And what complicates the pictures for ocular graft versus host is a lot of us get dry eyes as we get older. And a lot of that dry eye could be pre-existing. So I always tell my patients, if you can come ahead of time to see the eye doctor, it's always better to get a baseline exam so we know where you start and where we're going afterwards so that we have a form of comparison. I don't routinely start patients on treatments beforehand, but it is something that I think about. I think it's just important to talk to your bone marrow transplant team to get in touch and looped in with an eye doctor who's familiar with graft versus host so that we can carefully monitor you to figure out if you get it, and if you do, how early we can treat. So before I get to the summary, I just want to talk about things that you can do for self-care. Artificial tears are one thing that I think are easy to do. They're over the counter. I do prefer preservative-free. One of the reasons I prefer it is there is a bit of toxicity to preservatives. And although most patients don't use it in a high enough doses to get to a preservative irritation, which is usually if you use it more than 4 times a day, even still, the patients with graft versus host or patients that have had bone marrow transplants often have a more fragile ocular surface. So if we can do anything to minimize preservatives and any toxicity that may come from drops, I like to do that. So that's why I recommend preservative-free. And I recommend starting with 2 to 4 times a day if needed. And if needed would be if you come in and you have burning or irritation or dryness, that's when you would put it in. I think another safe thing to add is a warm compress. And you can do this with a washcloth. Just keep it warm 5 minutes a day. I often tell my patients, do it in the shower. When you're in there anyway, you've got that warm water coming on consistently or constantly so it can keep it warm. There are also glasses and night goggles, as I showed in the picture, that can be really helpful for patients. Many of my patients have a lot of dry eye when they go outside. It's cold, it's windy, and when that hits the eyes, they tear a lot or they get irritation. There's a website called dryeyeshop.com that has a great selection of day and night glasses that can help protect the eyes. And so I think those are things that patients can do even before seeing the eye doctor as simple ways to treat graft versus host without any medication or any prescriptions necessary. So in summary, ocular graft versus host can lead to disabling pain and blindness if not treated. But early detection, early diagnosis, early treatment are really keys to preventing long-term complications. We can do a good job as a team if we see you early and we treat you appropriately based on what's going on. I like to evaluate patients as early as possible and even pre-transplant if that's feasible. So that is everything I have for you. Please let me know if you have questions. I see a bunch in the chat box, but I will turn it back over to Becky.
All right. Thank you, Dr. Ciralsky. This was an excellent presentation. We will now begin with question and answer session. If you have a question for Dr. Ciralsky, please use the chat box on the left side of the screen to submit your question. We will answer as many questions as possible. So our first question today is, Dr. Ciralsky, once a GVHD patient has severe dry eyes, does this ever get better or is it permanent?
That's a great question. I would have to see the patient to be able to answer that accurately, but I can tell you when the dry eye has affected the lacrimal gland, that's the gland in the upper outer parts, that can't come back. So the patient may always have dry eyes, but it can be tolerable and treated so that you can live your life normally. Sometimes when it's the acute graft versus host, some of that can be reversed, but many times with the chronic, if the lacrimal gland has been affected greatly, that cannot be completely reversed. So some of it can be, but not all of it.
Thank you. We have another patient who's asking if GVHD of the eye eventually leads to vision loss, that they've been struggling for themselves for 2 years with a lot of different treatments and drops, and they really can't tell if their visioning is worsening just due to the constant pain, and that they just really hate to open their eyes. So again, can it lead to permanent to vision loss?
So the answer is yes. It can lead to vision loss, but it is rare for it to lead to vision loss. Usually when there is vision loss, it's because they have a scratch on the eye or they have scarring on the eye from either an infection or from a scratch. And that kind of vision loss can be treated eventually with a corneal transplant. But many times patients feel as if they have vision loss because it's trouble. They have such a struggle to open the eyes. One way to tell is for a doctor to put in a numbing drop in the office. And if you can see well with the numbing drop, then that means your vision is probably okay, although you may still have the dryness, so it's not a perfect test, but at least it will have you open your eyes and see where your vision is. You also, if you're struggling that much, treatments aren't working, and you can't even open the eyes, that's when I would turn to something like a contact lens. That would be a severe case of graft versus host in the eyes, and I think something like a contact lens would be something I would recommend to help with both vision and dryness at the same time.
Thank you. That was a difficult question. Actually, another question for our patients, and I see this as we're also starting to transplant patients a little later in life, but also secondary to other treatments. So this patient is on glaucoma drops, so as well as using a Bruder mask and cleaning their eyelids. They were wondering about your suggestion of the gel drops at nighttime. Would there need to be what kind of progress would that need to be? Would they need to do their glaucoma drops and then wait a couple hours and do the gel, or what's the process there?
Great question. Yeah, 5 minutes between drops is all you need. You always want to put the thickest one in last. And I prefer ointments at night versus gel drops just because they last longer, but 5 minutes is plenty of time. One other thing I want to bring up with glaucoma drops is they often have preservatives. And so for patients where the dryness is severe, even on glaucoma drops, you do want to wonder, are the glaucoma drops contributing? I'm not sure that was this patient's question, but if they are, they do make preservative-free glaucoma drops. Going back to why we like to get rid of preservatives, they can have an effect on the dryness.
Very good. Didn't know about the preservative glaucoma drops, so that's good to know. All right, perfect. Our next question is, their tear ducts no longer work. What can they do about that?
I'm not sure if I know exactly what they're talking about. So there's two ways that many times patients talk about the tear ducts. If the tear ducts are the drainage system and they're having too many tears because the drainage system isn't working, and I may have them clarified to make sure I'm answering this correctly, but if the tear ducts, which are the ducts for the drainage system, aren't working and the patient has too much tearing, sometimes those ducts can be opened. If the tear ducts they're talking about are the lacrimal glands, which are the glands that are producing tears, aren't working anymore, that is sort of back to our first question, which is it sort of reversible? And if the lacrimal glands aren't producing tears anymore, many times we cannot reverse it. And then what we have to do is bring tears to the surface externally. And so that's where we bring things like artificial tears in, or maybe that is someone who needs to be in that scleral lens to bring the tear on the surface every day. So I hope I answered that one well, but if that patient can maybe clarify what they were asking if I didn't answer it correctly.
Sure, thank you. And so here's another question I think is also relevant for a lot of our patients. A lot of patients, either due to age or the therapy they've gotten, have cataracts. So is it advisable to have cataract surgery if a patient is on immune suppression?
So that doesn't bother me at all from a cataract standpoint. The eye has its own immune system, which is nice. We have what we call immune privilege. And so I do cataracts all the time in graft versus host. Obviously, we need your doctor to sign off on it, to say that you're healthy enough to have it, because you do have to have some anesthesia. It's a mild anesthetic. But I'm not at all worried about the immunosuppression part of it. I will say the part that worries me the most, and I am a cataract surgeon who does a lot of GVHD cataracts, is that I'm going to make you drier with cataract surgery. And so for about 3 months after cataract surgery, all patients, GVH or no GVH, are going to be more dry than they were to begin with. And so if you're starting with dryness and then you get more dry, this can be really difficult after cataract surgery. This can limit your outcome. This can limit your, or this can make for a longer course. And so what I always tell my patients is we have to optimize that ocular surface before we go to cataract surgery. And so that's really important to mention.
Okay, perfect. So we have another question here is, how does the patient differentiate, or the physician differentiate, ocular neuropathy from ocular GVHD?
Yeah, that is a hard one. Ocular neuropathy, and I think what you're asking is what we call neuropathic pain, is a more complicated one. Ocular neuropathy or neuropathic pain usually means that a patient looks good. They come to our office and they have nothing on exam. All those tests I was showing where we look at all the different pictures, they look great. There's no staining, there's no red eyes, there's nothing, but the patient is miserable. What's hard about this is we see that sometimes with dry eye. Symptoms and signs don't correlate, so a patient can feel terrible and we don't see much. But ocular neuropathy is rarer in this group of patients, in my experience, than other patients. Patients who have had LASIK or patients who have had surgeries where we cut nerves are more common. It's more common to have ocular neuropathies. But the way that you differentiate this, for me, is when they come to the office, I put that numbing drop in them and I ask them if their pain goes away. If their pain goes away with that numbing drop, that means that it's on the surface. That surface, which is the part you can touch of the eye. If the pain goes away, that means I can use some of my treatments that we talked about to help you. If they still have pain despite that numbing drop, that means that the pain is coming from somewhere deeper. Maybe a nerve is being triggered, and then they have to think about systemic medicines that treat neuropathic pain.
Perfect. All right. Thank you so much. One of our other questions is, does the preservative in Sustain Eye Gel increase the chance for possible inflammation if you use it at night?
Does the preservative? I see it now. Okay. It should not. No. Many times with the gels, they are using such a nice preservative. I think you even put it in there. It's not what we call BAK. BAK is it has a much longer name, but that's the preservative that's in many eye drops that is the most irritating of the group. The gels, the ointments, they often carry a preservative that is very gentle on the eye. So when I think about gels and ointments, you don't need to find them preservative-free. I stress that more with the artificial tears.
Okay, very good. Another question comes with, is it safe to have shunts put in for glaucoma after a bone marrow transplant?
Yeah, I mean, if you need it for glaucoma, then you need it. And I always tell my patients, I'm in charge of the front of the eye. Yes, it has a lot of problems that can be had in terms of symptoms and in terms of vision, but for the most part, I have treatments. I can fix things. Even as far as a corneal transplant, if I need to, you don't go blind from the front of the eye problems typically, but you can go blind from glaucoma. And so if you need a shunt for glaucoma, I am always for it. Can it increase the dryness? The answer is yes, and sometimes we need to be more aggressive. But I always, if a patient needs retinal surgery, glaucoma surgery, I think it's important to treat that. Regardless of the dry eye, we just have to be more aggressive with the dry eye.
Okay. I have a patient here who is noting that they have worn contacts for decades. Is there any comment on wearing standard contacts with dry eye that comes and goes?
Um, Again, this may be a little bit of an individual answer for each patient in that I have seen plenty of patients that have mild dry eye after bone marrow transplant, and they can wear their standard contacts, and that's fine. And maybe for a week, a year, they have a little irritation. We take them out of contacts, treat them maybe with a week of steroids, and then they go back to their soft contacts. But if soft contacts work for the patient and you're being evaluated and everything looks fine, that is okay. I only leave those specialized contacts for patients that fail other treatments.
Okay. One of our patients is actually, this is good for HCP communication. So once you return to your regular optometrist, how do you address the dry eye portion since they are not usually familiar with graft-versus-host-disease?
You know, that's such a hard one. It may be something where you have a ophthalmologist who's a specialist in graft-versus-host, who's sort of the captain of the ship, and then maybe the optometrist who is someone that sees you regularly. And what you may do is just have good communication between the two because, you know, optometrists, it depends how, I guess it depends how comfortable your optometrist is. We have an optometrist at our practice who's amazing at dry eye, and she actually fits our patients for that scleral lens. And then there's optometrists that may have no experience with it. So I think it's a little bit individualized in this question, but I would say that if they are unfamiliar, you probably need someone that is familiar to be driving the ship. And so maybe an ophthalmologist who's maybe a cornea specialist or does dry eye, even if it's not only GVH dry eye, to see you once a year to sort of check in and then interface with the optometrist.
Okay. So we have 5 minutes left in our question and answer, so I'll try to get to maybe one or two more. So what are your thoughts on intense pulse light IPL for I'm going to say this wrong, Meibomian gland malfunction?
Yeah, sure. You know, I don't have an IPL here, so I didn't show it, but similar to the two that I showed up above, the BluffX and the LipiFlow, I think it's another tool in our toolbox. I've seen some patients have wonderful results and others have okay results, so it's a mixed bag, but I think it's safe and it's a good treatment.
Okay. And I think we can get to another one here. Let's see. Is accurate detection and staging a limiting factor in prescribing effective treatments? Would improved diagnostic and tracking techniques improve the long-term patient outcomes?
Absolutely. I think that, you know, we need a more systematic way of detecting these patients, staging them, and then putting them into treatments. And so more and more work needs to be done to do this. I think we absolutely need better diagnostic and tracking techniques and more of a universal system so that we can you know, follow our long-term patient outcomes and then change what we need to do or put them into buckets so there's more of a diagnostic so there's more of a treatment regimen that's more standardized so we know how to treat patients. A lot of what we do is somewhat of trial and error, or everybody has their own treatment regimen that they put patients through. But absolutely, I think if we had more diagnostic and tracking techniques, it would be better.
I don't generally like to use meds, but needed Restasis for dry eye. It got better, so I stopped. For doctors, okay. Once it came back, I restarted. Any comments about this?
Yeah, it only works when it's on there. So um, there's no cure for the dry eye. So I understand many patients are hesitant to be on drops. I do think though it will only work when it's on there. And so stopping and starting is not the worst thing, but it takes almost 3 months for it to work. So you don't want there to be low-grade inflammation ongoing when you're not using it. For somebody that really hates meds, sometimes I will go straight to something like serum tears, which are made from your own blood, or scleral lenses, which don't use drops. And I think both of those are nice and don't have any active ingredients if someone is hesitant to use meds.
And okay, so let's do one more. We won't get a complicated one, but let's see. How can you tell if the lateral gland has been compromised? Is there a test for that?
Yeah, that Schirmer's test, which I'll pull up as well. You can see when I'm pulling the pictures up. Can you guys see that? Yeah.
Yes.
Okay. So this middle bottom picture is called a Schirmer's test. That tells you sort of about your basal tear production, how many tears you're making in a given 5 minutes. That's a good test for your lacrimal gland.
Oh, very good. I think that was our last question. So on behalf of the BMT Infonote and our partners, I'd like to thank you, Dr. Ciralsky, for all your helpful remarks. And thank you to the audience for your excellent questions. Please feel free to contact the BMT Infonet if we can help you in any way. And please enjoy the rest of your symposium. Thank you and goodbye.